Okay, so we're going to talk a little bit about the history of understanding psychological disorder, and um, that will bring us up to, we'll stop before we talk about current paradigms or ways of understanding psychological disorder, because we'll pick up with that in the next chapter. And so hopefully you read the book. I'm not going to go in these slides. I'm not going to, the information's here, but I'm not going to talk in detail about the history. I'm assuming you've read that. I'm assuming you can read it here. So I'm just going to have kind of a background conversation, which is that if we go back to the beginning and first understanding of psychological disorder, if what the beliefs were feel silly to us sometimes. They feel almost laughable. What we need to remember is that always, including now, our understanding of psychological disorder is always going to, be tied to whatever our basic science is, and that when we lacked basic science, and when we used religious explanations to explain lots of natural phenomena, then we did the same with psychological disorder. And so it's not that we only did it with psychological disorder. Um, it's not until the Middle Ages, 1600s, right after the Middle Ages, as we move towards the Renaissance, it's not until then that we actually have an understanding of psychological disorder as something that we should respond to with treatment. And so in the 1600s, we get the first mental hospitals in Europe that become relatively common. And the most famous of those is Bethlehem Hospital in London, which the word Bedlam, which means chaotic, comes from. But even though we have these hospitals, we continue to see people with psychological disorder very much as other. And of course, at this point, if people are in the hospital, we're mostly going to be looking at psychological disorder as the most severe of the disorders we have. And so mostly this would be people probably with psychotic disorders like schizophrenia, or perhaps manic disorders like bipolar disorder, that people who were able to function any better than that probably wouldn't have wound up in the hospital at this point. It doesn't mean they were doing well. It just means that they were not needing to be shackled, which was the response at the time. And then, if we move ahead to the colonial era, and especially the colonial era, the colonial era in the U.S. Sorry about that. Let's try this again. So in the colonial era, we get the first mental hospitals in America. Of course, they couldn't have had them before then because we were not a country yet. But still, right, we're not really talking about treatment as we understand it. And then, during the 1800s, we do see the start of what Pinnell called moral treatment, though Pinnell claims is given responsibility for that, that probably really belongs to a patient who advocated to be unshackled or to have others unshackled. And in the late 1800s, Kreplin develops the first diagnostic system that includes the Latin for premature dementia, and this is the first attempt to label schizophrenia as a specific disorder. There's an interesting history for psychiatric hospitals in the U.S. In the mid-1800s, we get the opening of state hospitals in many states across the country, and many of those state hospitals still are open and exist. Our example in Connecticut is Connecticut Valley Hospital in Middletown. CVH used to be one of 3 hospitals in the state, state hospitals in the state: Fairfield Hills and Norfolk, not Norfolk. Now I'm going to forget. Up near New London, and I'm blanking now on the name of it. Norwich State Hospital were the 3, and then in the 1990s we closed Fairfield Hills in Newtown and Norwich up by New London, mostly for financial reasons. So we have about 1/3 of the beds available now that we did a few decades ago, but they were all built in the 1800s. And you can see here in these pictures that I've provided, the one on the left here is an old 1800s, maybe it might be the early 1900s picture of CVH when it was a relatively new building. I think it is the 1800s, especially judging by the age of the trees there. And then on the right is a picture of the same building currently. And so CVH is still open, but it is a different place in many ways, than it was during much of its existence. And so CVH, like many hospitals in the time, were self-sufficient, and so they employed so they employed uh, patients to work. Now, employ is probably the wrong word. They used the patients to work at the hospital and to keep the hospital running as a self-sufficient community. So that included farm work, that included digging reservoirs, that included, kind of working in various aspects of the hospital to make things run. What it meant is that CVH wasn't just a hospital, right? That you got up in the morning and you had things you needed to go out and do. I think that there were some advantages to that in terms of people having a sense of purpose. But obviously, making people work whether they wanted to or not is not acceptable. And so that stopped at some point in the middle of the 20th century. Um, and in some, obviously in some very important ways that was important. In other ways it means that that turned into the image that many of us have of what state hospitals might look like in the movies, for example, or on television, where people are sitting around a lot of the day watching television. And that is not necessarily a better thing in terms of mental health. And I wish that there had been some balance that could have been struck there. Um, and then, so in the 1970s, we get a lot of people discharged from state hospitals in response to a program that JFK started to try to get people out from being, quote unquote, warehoused. And in the 1990s, again, not just Connecticut, but nationwide, we get this effort to save money by moving people to less restrictive treatment settings, such as group homes. Um, and so, throughout this time that we're talking about, we do get this rise of medical treatment and a focus on the idea of biological etiology, especially in the US. Etiology is a word you and I will come back to a lot. You'll hear that word over and over. It means causes of a disorder. And so the US focuses a great deal on biological etiology and biological treatments because, of course, if you believe something is caused by biological forces, then you often are going to respond with treatment that is biological. And so electroconvulsive therapy, ice baths in the middle of the 20th century, prefrontal lobotomies in the middle of the 20th century, and then finally medication starting in the 1960s. Interestingly, Europe stays much more focused on psychological etiologies, and that largely focuses on theories related to Freud's idea of psychoanalysis. And we get some of that in the US, but we focus less on it than Europe does. And in the US, we also get a great focus on behaviorism, especially rising in the 1950s, and then later that became cognitive behaviorism. We'll talk more about those, all of those in the paradigm chapter, which is next. And so I'm not going to go into detail about any of that here. And so the last thing I want to just touch on a little bit here is just a word about professions with that relate to psychological disorder. And so, many people have a hard time distinguishing between psychiatrists and psychologists. I'm a clinical psychologist. Clinical psychologists are trained, have PhDs, doctorates that train us to diagnose and treat mental illness. There's an alternate to the PhD, it's a PsyD, which doesn't include as really training and research the way the PhD does, and it's just a clinical degree, but both are doctorates in clinical psychology. Psychiatry, on the other hand, are people who go to medical school, right? So to get a PhD, it's about 5 or 6, maybe 7 years after your undergraduate bachelor's. But in the whole time, you're studying to be a psychologist. Psychiatry, you go to medical school after your undergraduate degree, the same way that a cardiologist would. And then after you finish medical school, you choose to specialize your residency training in psychiatry. And psychiatrists are sometimes trained in doing psychotherapy, but the focus for psychiatric training is much more on medication and biological and pharmacological treatments. And then other degrees that work in this field, right? I bet some of you might be planning to get a degree in social work. and that's a 2-year degree at MSW after your bachelor's degree if you want to become a therapist, and then you have to get specialized licensure to become a therapist. There are also licensed professional counselors, which is also a master's degree, and then licensure afterwards. And then more and more, we're seeing lots of psychiatric nurses in the field who take the place of psychiatrists in terms of what role they fulfill. Some of them do therapy, but often their focus also is on medication. And in my practice, I work with both psychiatrists and APRNs, psychiatric nurses, who might see my patients much less frequently than I do, maybe once a month, maybe once every 3 months to prescribe medication. And so, we can certainly feel free to ask questions when we're live about these things, but I just wanted to give you that overview as well. And so that draws our lectures for this chapter to a close. And in the next chapter, we'll talk more about individual theories that help inform how we think about these in current life.